Hello nurses, good morning everyone. So today we're going to do rationalization of your post-test. So nagkaroon kayo ng dalawang post-test. We have your endocrine and we have your cardiovascular system concepts. So start tayo sa ating endocrine system. Okay. Number one, a client has been hospitalized for impaired function of the posterior pituitary gland. The nurse providing care for the client anticipates that the client may exhibit altered secretion of which of the following hormones? Is it A, antidiuretic hormone, B, growth hormone, C, follicle stimulating hormone, or DOG, luteinizing hormone? Okay, so you have to highlight there posterior pituitary gland. So ang when you speak about endocrine system, pag sinabi nating endocrine system, the main function of which is to maintain or to stabilize homeostasis of the human body. Okay, so as you can see in the picture, maraming part ng katawan natin na merong ganyang role. So the different organs will include hypothalamus, we also have pituitary gland, pineal gland. So dahil yung mga organ na yan ay part ng your nervous system, we can now say that your endocrine system, it works hand in hand with your nervous system for the maintenance of our balance. So partner sila para magkaroon tayo ng homeostasis. Pero bukod doon, other organs will include thyroid gland. We also have parathyroid, adrenal, your pancreas, and also your reproductive organs such as your ovaries and the testicles. Okay? So, ang tanong kanina sa question number 1 natin, it's asking for problem associated with impaired secretion of your posterior pituitary gland, right? So, mag-focus tayo ngayon sa ating pituitary gland. As I mentioned to you last time, when we speak about pituitary gland, nahati siya sa dalawa. May dalawang portion siya. So, yung harap at meron tayong likod. Now, anatomically, mas malaki yung anterior pituitary gland natin. So, ibig sabihin, mas maraming hormone po dyan, right? So, we have main hormones that are being produced in your anterior pituitary gland include meron tayong mnemonic, your GT-PAL-FM. So, ano yung mga hormone na nandyan, guys? We have G, for the growth of your tissues and bones, we have growth hormone. T is your thyroid stimulating hormone para yan sa production ng ating thyroid hormones, your T3 at saka T4. We also have your P for breast milk production, that's your prolactin. Letter A is ACTH or adrenocorticotropic hormone para naman yan sa ating steroid production. Letter L is luteinizing and your F is your follicle stimulating hormone para naman yan sa mga reproductive functions natin, right? For example, menstruation, ovulation, production of your hormones, male and female sex hormones. Yan ang responsibility ng ating luteinizing at saka ng follicle stimulating hormone. And the last one, we have your letter M, your melanocyte stimulating hormone. This will be related now to the production of your melanin. So, kailangan naman natin ng melanin for our skin color. Okay? So, ayan yung ating anterior. The posterior part, posterior, tandaan nyo lang posterior. So, ibig sabihin, meron lang tayong dalawang hormone dyan, and that will be your OA. O is oxytocin for the contraction of the uterus during childbirth, and also kailangan mo din yan para magkaroon ng ejection ng milk sa ating breast. We also have your letter A, antidiuretic hormone, also known as your vasopressin. So from the term antidiuretic, pipigilan kanyang umihi. Vasopressin, ibig sabihin naman ng vasopressin, it will press or it will constrict your blood vessel. So, ang antidiuretic hormone natin, bukod sa pinipigil niya ang pag-ihi mo, guys, you have to remember also, i-constrict niya or ipipress niya yung blood vessel. Therefore, it can cause hypertension. Okay? So, now, balikan, tignan pa natin tong picture. Yung posterior pituitary gland natin, as you can see, kung titignan mo, mas direct yung link niya sa ating hypothalamus, which is part of your nervous system. So, anong ibig sabihin ng anatomical structure na yan? Ibig sabihin, guys, itong OA natin, yung OA na tinatawag natin, these hormones are not actually produced in your posterior pituitary. Hindi yan ginagawa ng posterior. It will only serve as what? As storage house. Ang gumagawa talaga niyan is the hypothalamus. So kapag nakagawa na si hypothalamus, ibabagsak niya, ibababa niya dun sa ating posterior pituitary gland. Okay? So there you go. Those are the hormones that we should remember whenever we talk about your pituitary gland. Okay? By the way, additional information, pituitary gland is also known as hypophysis. So please do not forget that hypophysis. Baka kasi yan ang gamitin. Minsan kasi ang mga board natin, mahilig silang gumamit ng mga different different terms for different concepts. So when you see the term hypophysis, ibig sabihin yan pituitary gland. Kaya nga yung procedure kung saan tinatanggal yung pituitary gland, ang pangalan nun ay hypophysectomy. Okay? So, going back to the question, guys. So, may problema tayo sa posterior pituitary gland. Posterior, dalawa lang maaaring maging problema natin dyan. Okay, so the best answer here is definitely your letter A. So, magkakaroon tayo ng problema sa ating anti-diuretic hormone. Okay. Number 2, a male client with history of hypertension is diagnosed with primary hyperaldosteronism. The diagnosis indicates that the client's hypertension is caused by excessive hormone secretion from which of the following glands? So, please take note of hyperaldosteronism. So, meron siyang napakaraming aldosterone. So, yun daw ang dahilan kung bakit siya merong hypertension. Okay. So, aldosterone is a steroid. So, steroid siya. So, since it's a steroid, saan po siya nagmumula? So, saan siya galing? Is it A, adrenal cortex, B, pancreas, C, medulla, or letter dog, your parathyroid? Okay? So, ito yung ating adrenal gland. So, adrenal, meaning nakapatong lang siya dun sa ating kidney. So, meron tayong dalawang kidneys, the right and the left. The right kidney is lower than the left kidney kasi sa taas ng right kidney mo andun yung ating liver. So medyo binababa niya ng konti yung kidney natin. Now on top of your kidney may nakapatong na pangalan ay adrenal gland. So kung hihiwain natin yung adrenal gland mo, meron tayong gitna, your medulla, at meron tayong gilid, that will be your cortex. Okay? Sa medulla, guys, anong nandyan? Mga catecholamines. Catecholamines, ano yung mga yan? Catecholamines will be your epinephrine, ang ibang pangalan niya adrenaline. We also have norepinephrine, ang ibang pangalan niyan, norepinephrine. So, basically, if we're talking about medulla or catecholamines, ang na-i-stimulate natin dyan is your sympathetic nervous system. Okay? So, fight or flight, yung mga magiging manifestation mo kapag may problema tayo sa ating medulla. Okay. So, sa cortex naman natin, cortex, guys, tandaan mo lang, dito na papasok ang ating mga steroids. Okay? So, nandyan yung ating mga steroids. You have to remember steroids, cortex, kasi dyan papasok yung konsepto natin about Cushing, at saka yung Addison. Right? So, mamaya, mas mas maiintindihan kasi natin yung sakit kapag alam natin yung anatomy natin. Okay. So, for number 2, again, since we are talking about aldosterone, which is a steroid, ang tamang sagot natin dito is letter A. It is being produced by adrenal cortex. Okay? Next one, number 3. Ano yung number 3 question natin? A client with tentative diagnosis of hyperosmolar, hyperglycemic, non-ketotic syndrome has a history of type 2 diabetes. Which of the following is the most important laboratory test for confirming this disorder? Is it A, serum potassium level, B, serum sodium level, C, ABG values, or letter dog, serum osmolarity? Okay, so DM ulit. No? DM mo lang yung problema natin. HHNS, it's a complication of type 2. So, anatomically again, when we speak about diabetes, ang problema natin pancreas, no? So, ang pancreas, we have what we call as the islet of Langerhans, and inside that pancreas, we have cells. The first one, we have here your alpha cell. So, meron kang alpha cell dito. Okay? Ang trabaho ng alpha cell natin, tagagawa po siya ng ating glucagon. So, please take note, glucagon. Nakikita mo dyan, glucose. So, anong pwedeng gawin ng ating glucagon? Ito ay nakakapagpataas ng ating blood sugar. Okay, another kind of cell, sa baba, meron tayong beta cell. Okay, ang beta cell naman natin, ang trabaho niyan, tagagawa naman ng insulin. Tagagawa ng insulin. So, ang trabaho naman ng insulin natin, pampababa ng ating blood glucose. So, sa DM, ang problem natin dyan is your insulin level. Okay? So, ang problema natin is your beta cell. Right? So, we have discussed the difference between your type 1 and type 2 last time. So, i-recall ulit natin. So, for type 1, the onset of which is juvenile. So, pangbatang sakit ito. Ito yung diabetes na pagkapanganak ng tao o kaya ng bata pa lang siya, meron nang nakitaan na ng problema sa kanyang insulin production. So, this is juvenile. Ang insulin level niya, maaring ito ay konti o kaya naman wala. Okay? Zero. So, talaga totally wala siyang insulin. Body build, just like what I mentioned last time, sabi rin ni Doc C, pagka type 1, isipin mo lang si Gary V. So, mataba ba si Gary V? Hindi. As a matter of fact, he's very thin. Nung kabataan niyan, sobrang payat niya. Okay? So, Gary V is thin. So, the body build is thin. Typical management natin. So, sa type 1, since talagang problema niya ang insulin, so you have to expect that the management is the use of insulin. So, ilagay ko lang dyan, letter I. Ano pa? Importante din, kailangan niyang mag-diet. So, ilimit niya yung caloric intake niya. And when you say calorie, magbabawas tayo ng amount na kanyang kinakain. Okay? Pipiliin lang natin yung talagang akma sa kanyang health condition. Okay? And of course, aside from diet, we also advise them to do exercise. So, yan ang mga health teaching natin sa kanila, sa mga type 1. So, bukod sa insulin, patient, kailangan din nagda-diet, at tapos, kailangan din nag-exercise. For the complication, ang taong may type 1, ang mga cell niyan, you have to expect na starving. They are starving due to the lack of glucose, right? So, naalala niyo yung diagram natin dati? Okay, so ito yung ating diagram. So, this is your blood vessel. In your blood vessel, we have your glucose at meron ka ding insulin. So, lahat ng kinakain mo, nagiging glucose siya. Now, glucose, hindi siya pwedeng magstay lang sa ating blood vessel. Kailangan niya makapasok sa ating cell para mabuhay siya. Right? So, ang nagpapapasok sa kanya will be your insulin. So, yung susi saan. So, sa type 1, ang nangyayari, dahil nagugutom na yung mga cell, actually, this can also happen in your, ang pagkagutom ng cell, nangyayari din yan sa type 2. Kaya lang, yung pag-utilize ng fat, it's more of type 1 problem. Okay? So, pagka nagutom mo yun yung cell, hanap siya ng ibang pagkain, this time, hanapin niya yung fats. So, hanapin niya yung fats. Gagawin niyang source of energy yan. And fats, waste product po niya is your ketones. So, meron tayong waste product na ketones. And ketones, they are acid. So, kapag ka nag-build up ngayon yung ketones sa ating katawan, the patient may experience what? Your ketoacidosis. So, nagkakaroon po sila ng ketoacidosis. Okay? That's why, for type 1, ang problema natin sa ating type 1, ang complication natin dyan, we have your diabetic ketoacidosis. So, ano yung mga manifestation ng ketoacidosis natin? Of course, present pa rin dyan yung ating polyuria. Dehydrated yung mga pasyente. Ano pa? Since merong ketone, yung kanilang hininga parang, mayroon silang parang fruity yung kanilang hininga, parang acetone breath. Right? And if a person is suffering from acidosis, isa sa mga compensatory mechanism niyan is huminga ng malalim. Malalim at mabilis para ma-expel yung carbon dioxide, which is an acid. We call that respiration as your cosmol. So, ang DKA, meron din silang cosmol respiration. Aside from that, the presence of ketone may also elicit abdominal pain. So, nagkakaroon din sila ng abdominal pain. Okay? So, the DKA, by the way, since type 1 yan, common yan nangyayari sa mga mas batang population. Okay. Now, we go to your type 2. Ang type 2 naman, ang onset niyan, adult. Okay, yung tipong okay naman yung insulin level mo dati, pero dahil sa lifestyle, for example, samahan mo na rin ng konting genetics, nagkaroon ka ng diabetes. So, adult yung onset. For the insulin, maaring ito ay konti rin, o kaya naman normal. Okay? Maring konti o kaya naman normal. Now, some people, kung normal yung kanilang insulin level, maaring magkaroon pa rin sila ng diabetes kasi nagkakaroon sila ng tinatawag na insulin resistance. It's a condition wherein you have enough supply of insulin kaya lang hindi mo siya magamit ng maayos. Kumbaga resistant na yung katawan mo dun sa insulin na yon. Okay? So that is what's happening in your type 2. Meron tayong insulin resistance. For the body build, they are usually obese. Okay? Usually obese. Management natin, dito papasok yung paggamit nila ng mga pills. So, maaaring mag-take ng metformin, o kaya glipizide, o kaya naman ng acarbose. So, these are your oral hypoglycemic agents. Oral hypoglycemic agents. Pero bukod dyan, pagka talagang hindi makontrol yung blood sugar ng patient natin, eventually, patients with type 2 may also use insulin. Pwede rin silang mag-insulin. Okay. And the same with your type 1, gaya ng type 1 natin, pwede rin natin silang i-advise na mag-diet at saka mag-exercise. Okay? So basically, parang pareho lang yung type 1 at saka type 2 in terms of management. The difference is, ang type 1, hindi gagana sa kanya ang oral hypoglycemic agent. Okay? Hindi gagana sa kanya ang oral hypoglycemic agent. Okay? And finally, for the complication of type 2, di sila gagamit ng fat, wala silang ketone, but their blood sugar is very high, at saka masyadong malapot, so hyperglycemic, maraming asukal, malapot, maraming laman, hyperosmolar, but it is non-ketotic syndrome. Okay. Now, anong mas mahirap i-manage dyan? DKA ba or HHNS? It is your HHNS. Mas mahirap. Nangyayari sa mga older population. Okay? So, mas maraming namamatay sa HHNS kesa kay DKA. Okay. So, going back to the question. So, ito yung picture ng difference nila, no? So, sa DKA natin, ito, sa DKA, payat na payat siya kasi type 1, di ba? Thin. Ang mga pasyenteng merong type 1. Tapos, meron silang ketones. Positive yan sa ketones. Kaya meron silang fruity breath, meron silang abdominal pain, ang respiration nila mabilis na malalim, your cosmal respiration. Okay? Sa HHNS naman, mataba sila kasi type 2 yan, obese. Walang ketone, negative yan for ketone. So, walang acetone breath, walang fruity breath, at wala ding abdominal pain, walang cosmal respiration. Pero ang meron sa kanila, meron silang neurological manifestation. So, nagkakaroon ng sakit sa ulo, may confusion, may headache, merong confusion. Yun naman ang pang type 2. Okay? So, mas mahirap i-manage yung HHNS natin. If you're going to compare the blood sugar, mas mataas masyado yung HHNS. So, for number, ano na yung tanong kanina? Nasagot na ba natin? For number 3, so ito, HHNS. So, again, complication ng type 2. Malamang sa malamang, kaya siya umabot dyan kasi masyadong mataas talaga yung kanyang blood sugar. And what is a laboratory test that will confirm na mataas talaga yung blood sugar niya or maraming laman yung kanyang, malapot yung kanyang dugo because of sugar? Potassium, sodium, ABG, or osmolarity? Definitely, the answer is your letter doc, your serum osmolarity. Okay, so we go now to Number 4, a client with type 1 DM is scheduled to receive about 30 units of 70-30 insulin. There's no 70-30 insulin available. So, as a substitution, the nurse may give the client what? Ano pwede nating ibigay sa patient natin? So ang prescription sa kanya, 30 units daw ng 70-30. Pero usually may mga, kasi may mga nabibiling naka-combine na. For example, Humulin, Nobulin, 70-30 yung mga yan. Pero kung walang available na naka-mix na talaga, so trabaho nating mag-mix. So kailangan nating mag-mix. Okay, concept about insulin. Ang regular insulin natin, anong kulay niya? Clear. Siya din ang kaisa-isang insulin na pwede mong ibigay through IV. So, pagka-emergency, for example, DKA, kasi complication na yon, ang binibigay nating insulin is the regular. Ang NPH naman, it is cloudy. So, cloudy siya. Funda. If you're going to mix two insulin, what should be aspirated first? So, we always follow the principle of clear first before cloudy. Unahin natin i-aspirate yung clear bago yung cloudy to prevent what? Contamination. Para maiwasan ang contamination. Kasi kung inaspirate mo yung cloudy, tapos i-aspirate mo yung clear, magiging cloudy na yung clear natin. Okay? So again, regular is clear and pH is cloudy. Walang available na premix na medication na 70-30. So, kailangan nating maghalo. Ang ibig sabihin ng 70-30, 70% ay ano? 70 means 70, it's in percentage. So, 70% should be what? Your NPH. Tapos, the remaining 30% will be your regular. Okay, so ganyan po ang paghahalo natin. So, dahil 30 units, so I hope you know you know your math. So, ang gagawin lang natin, mag-multiply na tayo. So, 70% times 30, that will be how many units? 21 units of NPH. Okay? 21 units of NPH. Tapos, 30% daw is regular. So, 30% times 30, that will be 9. So, the answer will be 21 units of NPH and 9 units of regular insulin. So, for this number, the correct answer is letter A. 9 units of regular and 21 units of NPH. Okay, next one. Number 5. A client with type 1 DM is admitted to acute care facility with diabetic ketoacidosis. To correct this diabetic emergency, which measure should the healthcare team take first? Anong uunahin daw natin? Is it A, initiate fluid replacement therapy, B, administer insulin, C, correct your DKA, or letter dog, determine the cause of DKA? So, DKA na, complication na ito. So, malamang yung blood sugar niya masyado nang mataas. So, ang tanong, ano unang gagawin? Magbigay ng tubig. Tama bang magbigay tayo ng tubig? Yes, tama yan. Tama bang magbigay tayo ng insulin? Yes, tama rin yan. Correct the DKA, tama rin yan. Determine the cause of DKA, tama naman lahat yan. Kaya lang ang tanong kasi, ano unang gagawin natin? Right? So, the best answer here, guys, is letter. Dehydrated ba ang mga pasyenteng merong DKA? Yes, dry sila kasi massive ang kanilang urination. So, importante yung insulin. But, you have to remember, guys, kahit na magbigay tayo ng insulin, kung hindi sapat yung fluid volume ng kanyang katawan, hindi rin magsa-circulate yung insulin. So, unahin nating magbigay ng fluid replacement. Okay? So, magbigay muna tayo ng tubig. I-hydrate muna natin yung patient bago tayo mag-insulin. Okay, now speaking of insulin, in this case, if we're going to give insulin, ang ibibigay natin dyan, yung something that will yield fast result. So, IV ang magiging solution dyan. So, IV insulin. What is the only insulin that can be given through IV? Nagbibigay tayo ng regular insulin. Okay. Now, additional concept. Kung naaalala ninyo ito, pagka nagbigay tayo ng insulin through IV, ano ang aasahan mong kasama nating ibibigay? Naalala ba yan? Whenever we give insulin through IV line, meron tayong kailangan idagdag or meron kang aasahan na ipe-prescribe yung doktor na idadagdag na ibibigay sa kanya. What is that? It is kailangan magbigay ng additional na potassium. Okay? So, i-recall lang natin yan ng konti. So, ito yung balikan natin yung picture natin. So, yan yung ating blood vessel. Sabi ko kanina, yung ating insulin, ay ating glucose, dadalhin niya ng insulin pa loob ng cell. Right? Now, kapag ang insulin natin ay binigay through IV, so mabilis. Pag binigay ang insulin through IV, habang pinapasok ngayon ng insulin yung glucose pa loob ng cell, merong sumasama. Anong sumasama? Si potassium. So, kung meron kang potassium dito, bukod sa glucose, lumalabas din si potassium. Okay? Pumupunta rin sa labas ng blood vessel. So, maari bang bumagsak yung kanyang potassium? Yes, there's a possibility. So, maari magkaroon ng irregular na rhythm ng heart yan o kaya magkaroon ng problema sa kanyang contractility. So you have to expect na kapag ka naka-IV insulin yung ating patient, baka ang doktor mag-order din niya ng additional potassium. Okay? So, nasagot ba natin yung number 5? Okay, very good. So, letter A muna. Well, laging tatandaan nyo na hydrate first before tayo magbigay ng insulin. Number 6, a client has glycosylated hemoglobin level of 9%. Based on this test result, the nurse plans to teach the client about the need to, anong kailangan gawin? Glycosylated hemoglobin. Hemoglobin is is a protein component of your blood. Yan ang dahilan kung bakit mapula ang ating RBC. So, anong kinalaman yan, ma'am? So, ito. Ang RBC natin, meron bang specific na lifespan yan? Yes. Tumatagal lang sila ng ilang araw. Tumatagal lang sila ng 120 days. So, parang nasa 3 hanggang 4 months. So, pagka namatay yung mga yan, syempre gagawa ka ulit ng panibago. Now, habang ikaw gumagawa ng panibago mong RBC, habang gumagawa ka ng panibagong set ng RBC mo, yung sobrang glucose mo sa katawan, dumidikit sa kanya. Kaya nga ang tawag glycosylated. Nagdumidikit siya, pumapasok siya sa loob. At hindi yan mawawala until mamatay uli yung RBC natin, which is 120 days. So, itong test na to, your HbA1c, glycosylated hemoglobin test, napakagandang test yan to determine kung gaano mo nakokontrol yung blood sugar mo for the past 3 months or so. Okay? So, kung marami nakadikit na glucose sa RBC mo, ibig sabihin, not well-controlled yung blood sugar. Pag konti naman, well-controlled yan. Okay. Now, the question is, what's the normal? Anong normal na value? Ilang percent ng asukal ng glucose ang kailangan nakadikit sa ating hemoglobin? Guys, the magic number is 4 to 6%. Okay, 4 to 6%. But to be more precise, ang nakalagay sa libro natin, dagdagan nyo lang ng tag 0.4 sa bawat side. Malabo na. Dagdagan nyo lang ng tag 0.4. So, the exact amount is 4.4 to 6.4% only. Ganyan lang dapat ang percentage ng glucose na nakadikit sa ating hemoglobin. Now, if we go back to the question, ang kanyang glycosylated hemoglobin level is nasa 9% na. So, masyado na itong mataas. So, what should you teach the client? Avoid infection, take fluid, recognize hypogly, or letter D, prevent and recognize hyperglycemia. Since mataas yan, mataas ang kanyang blood sugar, you have to prevent and recognize hyperglycemia. Okay? So, that will be our answer for that question. Number 7, a male client with type 1 DM has a highly elevated glycosylated hemoglobin test. In discussing the result with the client, the nurse Charmaine would be most accurate in stating A, the test needs to be repeated following a 12-hour fast. B, it looks like you aren't following the prescribed diabetic diet. C, it tells us about your sugar control for the last 3 months. Or D, your insulin regimen needs to be altered significantly. So, ano ang pinakamagandang pwede mong isagot sa patient natin dito? Mataas daw yung kanyang hemoglobin test. So, what will be your answer? Ano sabi ko kanina? Pagka ang asukal dumikit na sa ating hemoglobin, hindi na yan mawawala sa kanya hanggang mamatay uli yung RBC. Right? So, ano ang lifespan ng ating RBC? About 120 days or roughly around 3 to 4 months. So, the best answer would be letter C. It tells us about your sugar control for the last 3 months. Number 8. Ketones in the urine signal that there is a deficiency of insulin and control of type 1 DM is deteriorating. Hindi daw maayos yung control mo pag may ketones ka na. Using a urine dipstick, the strip will turn into what color if ketones are present? So, isa sa mga pwede natin gawin to determine kung meron ng complication yung patient is to do your urine dipstick. So, meron kang strip, ididip mo dun sa kanyang ihe, tapos hintayin mong magbago yung kulay. Pag nagbago yung kulay, it will signify na meron ng ketone yung patient. So, kung may ketone na siya, it tells us na gumagamit na yung patient ng fat as its energy source. So, eto ang sagot natin. So, you have to look for purple discoloration. At kapag ka mas malalim or mas dark yung pagiging purple niya, ibig sabihin mas marami na yung amount of ketone sa kanyang ihi. Okay? So, for that, the best answer is letter dog. So, nagiging purple. Number 9. A client who's taking metformin should be monitored closely for what adverse effect? Hypogly, B, lactic acidosis, C, flatulence, or letter dog, headache. Metformin is an oral hypoglycemic agent. Okay? So kapag ka nagtitake ang patient natin ng ganyang gamot, ano ang kailangan nating i-monitor? When this was asked in the board exam before, maraming estudyante ang sumagot dito ay hypoglycemia. Kasi nga naman, alam nila na ang metformin pang DM. So, ano bang ginagawa ng mga gamot pampababa ng blood sugar? So, kaya ang sinagot nila, hypoglycemia. But that's not the correct answer. Ang metformin, bawal tong ibigay sa mga pasyenteng merong sakit sa kidney. Why? Metformin can actually induce what? Your lactic acidosis. So, wag kakalimutan yan. Whenever you see metformin, isipin mo agad kidney. No? Isipin mo agad kidney. So, lahat na magiging sagot mo is something that is related to your kidney function. In this case, so naka-metformin yung patient, kidney. Masama sa kidney ang ating metformin. So, among the options, ano ang masama dyan sa kidney? Your lactic acidosis. Anything that's related to your electrolytes, to your output, for example, those are all related to your kidney function. So, for number 9, your answer should be letter boy. Okay? So, pag-usapan natin yung mga common pharmacologic drugs ng ating DM. So, again, for oral hypoglycemic agents, pwede ba ito sa type 1? Hindi pwede. Pwede ba ito sa type 2? Pwede. Pwede ba ito sa mga buntis na merong DM? Hindi rin po pwede. Kasi teratogenic ang ating mga pharmacologic drugs. Although may mga nakikita akong mga gamot over the internet, may mga nababasa na akong literature kung saan pinapagamit na nila ng pills yung mga buntis. Pero sa libro kasi natin na nakalagay pa rin doon, OHA is contraindicated sa mga buntis because it is teratogenic. Okay? So, common medications natin, for example, sulfonylureas. So, ang mga sulfonylureas natin, ang effect niyan ay sa pancreas. So, basically, kakalampagin niya yung pancreas. Uy, maglabas ka naman ng insulin. Yan ang kanyang trabaho. So, example is your glipizide. We also have your tolazamide. Glipizide or tolazamide. Again, it will stimulate the pancreas to produce insulin. Another kind of drug that is being advised or prescribed to DM type 2 patient will be your biguanides. Ang action naman yan is on the liver. Now, liver. Bakit anong kinalaman ng liver? Ang liver natin may nakatagong asukal dyan. Tama ba? Ang pangalan ng nakatagong asukal dyan is your glycogen. Okay? So, ganito siya, guys. Pag kumain ka, ang glucose mo nako-convert yan into ATP, right? Para maging energy natin. Now, minsan, yung sobrang glucose na hindi mo naman kailangan na itatago yan. Kumbaga, nag-iipon ka para meron kang reserba. Na itatago yan saan? In your liver, and pwede rin siyang maitago sa ating muscle. So, kapag nakatago na yung asukal, ang tawag na sa kanya ay glycogen. That in the future, for example, nagutom ka or nawalan ka ng glucose, yung glycogen mo, magiging glucose uli. So, magiging asukal mo uli siya. Okay? When you take biguanide, basically, ang gagawin ng biguanide natin, stop niya muna yung conversion ng glycogen into glucose kasi pandagdag yan sa problema. Okay? So, ang example ng ating biguanide is, there you go, we have your metformin. So, dyan papasok yung ating metformin. Again, metformin is has the potential to induce what? Your lactic acidosis. Therefore, bawal na bawal po siya sa mga merong kidney problem. Okay? Huwag kakalimutan yan. Bawal sa merong kidney problem. Okay? Another kind of drug being given to DM type 2 patient, we also have your alpha glucosidase inhibitor. Ang effect naman yan is on our intestine. Alam natin lahat na ang intestine, dyan nangyayari, specifically your small intestine, dyan nangyayari ang final absorption of nutrients. So, kapag ka nagtitake ka ng alpha glucosidase inhibitor, inhibit niya muna or i-delay niya muna yung absorption ng carbohydrates. Kasi pag na-absorb, di panibagong asukal na naman. Tataas uli yung blood sugar ng patient. So, it will delay the absorption of sugar or carbohydrates in your intestine. Example ng gamot, we have your acarbose. Okay. Now, clarify natin. Pagka metformin lang ang tinitake ng patient, a potential adverse effect is metformin lang, lactic acidosis. Pero pag ang patient natin, bukod sa metformin, nagtitake pa siya ng ibang gamot, for example, naka-insulin pa, o kaya naka-glipizide pa, hindi na natin isagot ang metformin. The answer will be hypoglycemia na. Pag metformin lang, lactic acidosis. Pero kung may kasamang ibang gamot, we answer hypoglycemia. Just like in your number 9. So here, the patient is taking metformin, number 10. Here, the patient is taking insulin, pero bukod sa insulin, nagtitake pa siya ng metformin. So, anong magiging sagot natin dyan? It's no longer lactic acidosis. The answer here is hypoglycemia na. Pag metformin lang, lactic acidosis. Pero kung may kasamang ibang gamot, hypoglycemia. Okay? Number 11. An elevated blood glucose on arising in the morning is caused by insufficient level of insulin, which may be caused by several factors. Which of the following is the correct description of dawn phenomenon? Okay. So, pag sinabi nating dawn, Tagalog niyan, di ba? Madaling araw. Okay? Ang mga diabetic patient natin, most of them, pagka nagising sila sa umaga, mataas yung kanilang blood sugar. Meron silang tinatawag na morning hyperglycemia. Isa sa mga explanation na yon is what we call as your dawn phenomenon. Okay? So, ang sinasabi ng phenomenon na yan, ang mga diabetic patient daw, sa umaga, around the 3 a.m., biglang tumataas yung kanilang blood sugar. Okay? So, dawn phenomenon ang tawag dyan. Yung letter boy, yung dawn phenomenon, ang explanation dyan, at around 3 a.m. daw, lumalabas kasi may lumalabas na hormone dyan na maaaring makapagpataas ng ating blood sugar. Example, yung glucagon. So at around 3 a.m., maaaring lumabas si glucagon and that will elevate the level of your blood sugar. Kaya pag gising nila, mataas ang kanilang blood sugar. Ang letter boy, nocturnal hypoglycemia followed by rebound hyperglycemia. What is this phenomenon? This is what we call as your sumugi effect or sumugi phenomenon. Ang sumugi naman, ang sinasabi ng sumugi, around madaling araw din, biglang bumabagsak yung blood sugar mo. So around the dawn also, around the 2 to 3 a.m., bigla ka nagkakaroon ng hypoglycemia. So bumabagsak yung blood sugar mo. Pero merong ano diyan, may gagawin yung katawan mo. So tawag dito, nung bumagsak yung blood sugar mo, ang gagawin ng katawan mo dyan, it will try to raise the level of your blood sugar by releasing your counter-regulatory hormone known as your glucagon. So, lalabas ngayon si glucagon. Ang resulta, biglang tataas yung blood sugar mo. Okay. So, by the way, letter A, yung dawn phenomenon, let me correct yung hormone. Ang hindi glucagon ang lumalabas around 3 a.m. na makakapagpatas, it is your growth hormone. Sorry about that. Again, let me clarify that. So letter A, that's your dawn phenomenon. At around 3 a.m., tumataas bigla ang yung blood sugar mo. Anong explanation nila? During that time daw, lumalabas yung growth hormone. And growth hormone can increase the level of your blood sugar. Ang letter B, this letter B is your sumugi phenomenon. Sumugi. Ang sinasabi ng sumugi, na madaling araw, baka nagkaroon ka ng hypoglycemia. At dahil dyan, gagawa ng paraan yung katawan mo para makorek yan by producing counter-regulatory hormone in the form of glucagon. Dito papasok yung glucagon. At pagka meron na yung glucagon, biglang tataas naman yung blood sugar mo. We call it as your rebound hyperglycemia. Okay? Letter C, progressive increase in blood glucose from bedtime to morning. So, nag-insulin ka nung gabi, na nagising ka, mataas ang blood sugar mo, kasi basically, nawala na yung effect. Ganun naman lahat ng gamot. Habang tumatagal sa katawan natin, nawawala na yung epekto niya. So, letter C, this is your theory about insulin waning. Insulin waning theory. Okay? So, again, when we speak about morning hyperglycemia in patients suffering from DM, we have three possible explanations. One is your dawn phenomenon, second is your sumugi effect, and the third one is your insulin waning. Okay? So, ang dawn phenomenon, tumaas ang blood sugar mo kasi meron kang lumalabas ang growth hormone ng madaling araw. Ang letter B naman, kaya ka mataas ang blood sugar, ang sumugi effect, kaya mataas ang blood sugar mo kasi nung umaga, na hypoglyca, lumabas si glucagon, nagkaroon naman ng rebound hyperglycemia. Ang insulin waning, which is your letter C, habang tumatagal ang gamot sa loob ng iyong katawan, nawawala siya ng effect. So, we call it as your insulin waning. So, ang sagot natin for number 11 is letter A. Okay? Next question. Number 12. After taking glipizide for 9 months, a male client, glipizide is your sulfonylureas, again, the effect of which is towards your pancreas. It will stimulate the pancreas to produce more insulin. A male client experiences secondary failure. Which of the following would the nurse expect the physician to do? So, nakaglipizide na yung patient, mag-iisang taon na, 9 months, pero nagkaroon ng failure. Ibig sabihin, hindi na ma-manage na maayos yung blood sugar ng patient. So, ano kayang gagawin? Letter A, mag-i-insulin na. Boy, switch the client to a different oral anti-diabetic agent. C, magdagdag ng panibagong agent. Or letter dog, restrict carbohydrate intake to less than 30%. Less than 30%. No. Actually nga sa mga DM patient, ang advice natin sa kanila, dapat ang pinakamarami pa rin carbohydrates. Less ang fat, less ang protein. Kasi ang fat saka protein, when you take them in, nagkakaroon sila ng waste product, which is detrimental or masama naman sa ating kidney at saka sa ating liver. So for diabetic patient, as much as possible, pinakamarami pa rin ang carbohydrates. So mali ang letter dog. So kung hindi gumana yung glipizide, ano na ang gagawin? Although po pwedeng mag-insulin na yung patient, pero usually ang ginagawa dyan, papalitan muna. Tatry muna sila ng iba kasi marami namang mga gamot pa, right? Just like what we have discussed a while ago. So for this number, ang expected na gagawin ng doctor ay maaring palitan. Switch the client to a different oral anti-diabetic agent. So 12 is letter 1. 13. The most common cause of hypothyroidism in adults. Anong pinaka-common cause? Hypothyroidism, ano nangyayari dito guys? Bumabagsak ang yung thyroid hormones, right? So, bagsak ang thyroid hormones ng patient dito. So, when we speak about thyroid hormones, that will be your T3 at saka T4. Responsible yan para sa ating metabolism. Okay? Sa metabolism natin. So, kung meron kang hypothyroidism, syempre bagsak ang yung T3 at saka T4, metabolism mo mababa. Okay? So, anong pinaka-common cause? It's usually your antibodies trying to attack na-atake niya yung thyroid gland mo. So, ngayon, hindi na siya makagawa ng, makapag-produce ng tamang supply ng thyroid hormones mo. We call it as your Hashimoto's thyroiditis, also known as autoimmune thyroiditis. Okay? That's the most common cause of hypothyroidism. Ito yung thyroid gland natin. So, butterfly shape. So, sabi natin, ang thyroid gland, it will produce T3, T4, and also what? Calcitonin. So, itong tatlo. But, calcitonin, hindi yan para sa, tag dito, calcitonin is for what? For calcium regulation. Pinapataas niya ang level ng calcium natin saan? Sa ating mga buto. So, pampatibay ng buto ang ating calcitonin. When we speak about hypothyroidism and hyperthyroidism, we are only referring to these two, your T3 at saka yung ating T4. Okay? So, yung mga yellow na naka-embed sa ating thyroid gland, ang tawag naman natin dyan ay parathyroid. So, ito ang difference ng dalawa. So, si hypo, saka si hyper. So, ito, yung payat na payat, payat na payat, yan ay si hyperthyroidism. Masyadong mataas ang kanilang metabolism. So, kahit na sobrang dami na ng kanilang kinakain, ano nangyayari? Masyado pa rin silang payat. Right? Ano pa? Meron din silang GI manifestation. They are constipated. They are suffering, no, not constipation. They suffer from diarrhea. So, tain ng tai yung mga yan. Very active ang kanilang peristalsis. Okay? For the vital signs, tumataas ang kanilang BP, tataas din ang kanilang cardiac rate or heart rate, may flashing of the face, masyado silang naiinitan, hindi nila parang kahit na malamig ang paligid, parang lagi silang init na init. And also, there is protrusion of the eyeball known as your exophthalmos. Okay? So, yun yung mga manifestation. Dahil sobrang active din ng kanilang thyroid gland, there will be enlargement also of the thyroid gland. Okay. Sa hypothyroidism naman, bagsak ang kanilang metabolism, bagsak ang kanilang T3 and T4F, mababa. So, bagsak ang metabolism nila. So, kahit na konti lang yung kinakain nila, they gain weight pa din. So, nagkakaroon ng accumulation of fat sa kanilang mga tissue known as your mixed edema. Nagkakaroon ng mixed edema. And GI symptom naman, mababa ang peristalsis. So, they are usually what? Constipated. Mababa ang kanilang BP, mababa ang heart rate, even respiration. What else? They also suffer from, parang lagi rin silang giniginaw. Kahit na masyadong mainit na ang paligid, parang laging giniginaw yung mga patient na yan. Worst case scenario for hypothyroidism, they may suffer from mixed edema, coma. Ang severe form naman ng ating hyperthyroidism, we have your thyrotoxic crisis or thyroid storm. Okay? So, for number 13, again, the answer is autoimmune thyroiditis, also known as Hashimoto's thyroiditis. Number 14, what important instruction concerning the administration of levothyroxine should the nurse teach? Levothyroxine, levo, para kanino ang levo? This is for hypo. Para ito sa taong masyadong bagsak ang metabolism. No? So, binibigay mo yan para pataasin ang kanilang T3 and T4. Right? So, kailan mo para pataasin ang T3 and T4 para tumaas ang metabolism, magkaroon ng energy? Kailan natin sila gustong mataas ang energy? Sa umaga or sa gabi? So, dapat ang energy nila mataas sa umaga. So, they can do their activities of daily living. Right? So, dapat umaga. And for absorption, ang levothyroxine, kailangan i-take mo yan nang walang laman ang tiyan. Kaya mali ang letter A, mali din ang letter C. Okay, mali ang A at letter C kasi merong pagkain. Food impairs the absorption of levothyroxine. So, which is better? B, take the drug before breakfast, or letter dog, take the drug before breakfast with full glass of water. Ano sagot natin dito? Okay, so take the drug before breakfast, tama yan, right? So kasi kailangan empty stomach sa to promote absorption. But between B and dog, anong mas better na sagot natin? Okay, it is letter, mas kumpleto, it should be letter dog. Okay, take the drug before breakfast with full glass of water. Okay, susundan natin siya ng full glass of water. Pero dapat walang pagkain. Okay, dapat empty yung stomach. Number 15. The nurse is assessing a client after thyroidectomy. The assessment reveals muscle twitching and tingling along with numbness in the fingers, toes, and mouth. So, even without looking at the options, immediately when you speak about thyroidectomy, tas biglang nagkaroon ng mga muscle twitching, tingling, numbness, ibig sabihin nito, you have to think of calcium automatically, right? So, ano kaya naging complication? Is it A, tetany, B, hemorrhage, C, thyroid storm, or letter dog, laryngeal nerve damage? So, itong mga to, yung mga nakalistang options, these are potential complications of thyroidectomy. Pwedeng magkaroon ng tetany kasi maaring tamaan si parathyroid. Remember, anatomically, nandun lang siya sa gilid, 'di ba? So, yung ating parathyroid, ayan yung ating thyroid, So, may maliliit na gland dyan, yan yung parathyroid. And parathyroid hormone is also for calcium regulation. Ang PTH natin, pampataas din yan ng calcium. Pero saan guys? Anong pinapataas niya? Pinapataas niya sa ating dugo. Kabaliktaran niya si calcitonin. Si calcitonin kanina, pampataas din ng calcium pero pinapataas niya sa buto. But parathyroid, sa blood naman. So, pagka tinanggal yung thyroid, maaaring matanggal din yung parathyroid hormone and that can lead to hypocalcemia as manifested by your numbness, muscle twitching. So, ang sagot natin dyan ay letter A. Hemorrhage can also be a complication. How do you assess for hemorrhage? Paano natin malalaman kung nagkakaroon ng bleeding yung patient? Frequent swallowing? No. Kasi ang thyroid, andito lang sa labas niyan. So, paano natin malaman kung nagdudugo? You just feel the neck and nape area kung merong dampness, kung merong dugo. Ngayon, doon natin siya malalaman. Thyroid storm, you look at the vital sign, kung masyado nang mataas ang heart rate, ang kanyang temperature, mainit na yung patient, thyroid storm. Laryngeal nerve damage. This nerve enable us to talk or to produce sound. So, after thyroidectomy, maari kasing madamage or maputol yan. So, how do we assess for that? You simply ask the patient to talk. Pag may hoarseness, garalgal yung boses, normal. Kasi after surgery talaga namang pwedeng mangyari yon. Nagiging hoarse yung kanilang voice. But kung totally wala na siyang ma-produce na sound, baka tinamaan yung kanyang laryngeal nerve. Okay? Number 16. Before undergoing subtotal thyroidectomy, a client receives potassium iodide, Lugol solution, and propylthiouracil. The nurse would expect the client's symptoms to subside when? So, kailan? Ang Lugol solution, binibigay natin yan para hindi madugo yung ating thyroid during operation. So, this will decrease the vascularity of the thyroid gland para hindi madugo. PTU para bumagsak ang production ng T3 at saka ng T4. So, agad-agad ba ang epekto ng mga yan? Hindi. Usually, you have to wait for how many weeks? It's about 1 to 2 weeks ang may kita yung effect ng mga gamot na yan. Okay? So, 16 is letter dot. 17, a nurse is monitoring a client with Graves' disease with signs of thyrotoxic crisis. So, Graves ang pinag-usapan. So, definitely this is hyperthyroidism. Which of the following signs and symptoms, if noted in a client, will alert the nurse to the presence of this crisis? Is it A, pallor and tachycardia, B, fever and tachycardia, C, restlessness and bradycardia, letter D, agitation and bradycardia? So, bradycardia, definitely tanggalin na natin yan kasi para yan sa hypothyroidism. So, is it A or letter boy? It is letter boy. Pag mainit, tapos mataas ang heart rate, that will be signs of thyroid storm. Number 18. A nurse is performing an assessment on a client following thyroidectomy and notes that the client has developed hoarseness and a weak voice. Mahina, may hoarseness. Which nursing action is appropriate? Is it A, check for signs of bleeding? B, administered calcium gluconate? C, ang calcium gluconate? C, notify the physician immediately? Emergency ba ang situation natin? Hindi. So, letter C will not be the answer. Dog, reassure the client that this is usually a temporary condition. So, which is better? Thyroidectomy. Ano sabi natin kanina, normal lang ba na medyo magkaroon ng hoarseness at saka humina yung boses? Pero kapag totally nawala yung boses, baka nagkaroon ng damage sa kanyang laryngeal nerve, right? So, in this case, pwede yung term na reassurance. Maaring in-avoid ninyo yung option na yan, but in this case kasi, hindi sa lahat ng pagkakataon mali yung term na reassurance, no? In this case, tama lang na sabihin mo na temporary condition yan. Normal na mangyayari yan after thyroidectomy. Okay? So, 18 is letter dot. So, maging discerning tayo. Hindi sa lahat ng pagkakataon mali yung term na reassure. Okay. Kasi kung talaga namang totoo naman yung sasabihin mo, reassurance is good. Pero, mag-ingat ka sa term na yan kapag usually psych yung patient or psych conditions. 19. A nurse is reviewing the physician's order for a client diagnosed with hypothyroidism Which medication were the nurse questioned and verified? Drug of choice for hypothyroidism, anong drug of choice natin? Levothyroxine. So, wag mong i-question kapag ka nagle-levo siya kasi yan talaga ang gamot niya. Acetaminophen, pwede ba niyang i-take yan? Yes, pwede yan kapag meron siyang fever. Okay lang yan. Colace, anong colace natin? Stool softener yan, pampalambot ng tae. So, kailangan ba yan ng mga merong hypothyroidism? May constipation ba sila or diarrhea? Since bagsak ang metabolism, they suffer from constipation, so okay lang take ng stool softeners. Okay? Ano ang bawal? Morphine sulfate. Because as we know, when we speak about morphine sulfate or narcotics, this can cause respiratory depression. So kung hypo tayo na yung patient, tapos nagtitake pa ng morphine sulfate, baka mag-slow down pa lalo yung kanyang respiration. Baka magkaroon ng respiratory arrest yung ating pasyente. Okay? So, 19, you would question the use of morphine sulfate. 20. A client has begun medication therapy with propylthiouracil. Propylthiouracil is a drug of choice ito ang drug of choice natin for hyperthyroidism. Pagka-hypo, levothyroxine. Pag-hyper, propylthiouracil. Pwede rin ang methimazole sa hyper, kaya lang kasi bawal siya sa buntis. So, ang propylthiouracil pwede sa buntis. The nurse would assess the client for which of the following as an adverse effect of this medication. So, nagbibigay ka ng propylthiouracil kasi hyper si patient. Tama? Binibigay mo yan para bumaba ang kanyang T3 at saka T4. Pagka nasobrahan naman, ano mangyayari? Babagsak yung T3 and T4. We call it as your hypothyroidism. Okay? So, that will be an answer for that. 21. The nurse is preparing to care for a client returning from the operating room following subtotal thyroidectomy. The nurse anticipates the need for which of the following items to be placed at the bedside. I think na-encounter na natin itong question na ito dati. So, subtotal thyroidectomy. Tinanggalan thyroid. Ano ang kailangan na sa bedside? Is it A, hypothermia blanket? B, emergency tracheostomy kit? Magnesium sulfate? Magnesium sulfate, ano yan? Antidote yan ng calcium gluconate. D, ampoule of saturated solution of potassium iodide. Pagka nagpa-opera sa thyroid, dahil may injury, maaring mamaga. No? Maaring mamaga, magkaroon ng swelling dyan sa mga tissues na yan. And that can what? That can impede or that can obstruct the airway. Sisikip yung daanan ng hangin. So, asahan natin na sa bedside, in case na magkaroon ng pamamaga dun sa injury, sa site of injury, kailangan naka-ready ang alin? Tracheostomy kit. Okay? Just in case gagawan ng airway yung patient natin kasi nga namaga na or nagkaroon na ng na-block na yung airway ng patient because of the swelling. So, 21, our answer for that will be letter boy. 22. The nurse is assessing a client with Cushing syndrome. Which observation should the nurse report to the physician immediately? Okay, Cushing, ang kabaliktaran nito is your Addison. Remember, Cushing and Addison, always remember steroid. At ang steroid natin, saan yan galing uli? Galing yan sa ating adrenal cortex. Okay? So, adrenal cortex, yung nasa labas. So, yung nasa labas. And these are the hormones or these are the steroids being produced by your adrenal cortex. We have glucocorticosteroid. Primarily your cortisol, yan ang ating stress hormone. Kailangan mo yan kapag you are under stress. Okay, so please take note of the term gluco. So when we speak of cortisol, you have to remember na kaya nitong magpataas ng ating sugar. Okay, so sugar. Ang sex hormone naman, responsible yan para sa ating mga secondary sex characteristics. Hair also, the growth of your hair is also due to the influence of your androgen. So, ilagay natin dyan, we have your sex. And aldosterone is a form of mineralocorticosteroid. As we mentioned last time, ang trabaho niya, it will retain sodium and it will excrete potassium. So, kung meron kang sodium, lumalabas ngayon si ating potassium. Ang layman term ng ating sodium is your salt. So when you talk about Cushing and Addison, you have to remember the three S's, your sugar, sex, and salt. And you also need to remember sa dulo, we have your potassium. Okay. Sa Cushing, mataas ang kanilang sugar, mataas ang androgen, kaya meron silang mataas ang androgen, kaya may mga hirsutism, may mga abnormal growth of hair, yung mga pasyenteng merong Cushing. Right? At dahil mataas ang aldosterone, mataas din ang salt. Kung mataas ang salt, mababa ang potassium. So that's your Cushing. Sa Addison naman, exactly the opposite. Ang sugar nila mababa, ang androgen mababa, kaya kung si Cushing may hirsutism, si Addison naman meron siyang alopecia. Okay? Ang salt naman mababa. Kung mababa ang salt, ang kanilang potassium ay mataas. So, napakasimple lang ng difference ng dalawang ito. Okay? For the physical manifestation, ang Cushing, mataba yan. Meron silang moon face, buffalo hump, truncal obesity, tas may mga stria, yung kanilang integument or kanilang skin, especially sa kanilang sa tiyan. Addison naman, physical manifestation, nagkakaroon ng bronze discoloration, yung kanilang balat. Okay. So, ito yung ating Addison. Addison, steroids ay mababa. So, nagkakaroon ng alopecia, meron silang hypoglycemia, hyponatremia, tapos, bronze skin discoloration. Sa Cushing naman, ang taas ng kanilang steroid. Ang resulta, meron silang hyperglycemia, meron silang excess of hair, hirsutism, and then, meron silang hypernatremia din. Mataas din ang kanilang sugar. Ang resulta nun, tumataas ang kanilang BP. Pag mataas ang asin, mataas ang BP. Okay. So, physical manifestation naman nila, may round face, moon face, buffalo hump, truncal obesity, and meron silang striae. Okay, striations. So, ito ang Cushing. This is your Cushing. And this is your Addison. Okay, ito, bronze discoloration ng skin. So 22. Anong kailangan nating i-report sa pasyenteng merong Cushing? So, always remember the 3S. Cushing, 3 S mataas. Anong mababa? Potassium. Okay. So, what will be your answer here? Edema of the legs. Ito bang kailangan i-report? Dry mucous membrane, frequent urination. Ang dry mucous membrane at saka frequent urination not usually associated with Cushing. Pwedeng yan, diabetes mellitus o kaya naman diabetes insipidus kapag ihi ng ihi. So, dahil sa Cushing mababa ang potassium, you always need to remember the heart, contraction ng heart, right? So, maaring magkaroon ng irregular apical pulse because they suffer from hypokalemia. Meron silang hypokalemia. 23. A nurse is providing discharge instruction to a client who has Cushing syndrome, which client's statement indicates that instruction related to dietary management are understood, naintindihan. Again, always go back to your 3S and your K. So, kung Cushing, mataas ang kanilang S, sugar, sex, and salt, pero mababa ang potassium. Lagi ninyong isusulat yan. So, alin ang tamang statement? Letter A, I can eat foods that have a lot of potassium in them. Tama? Yes. Boy, I will need to limit the amount of protein in my diet. C, I am fortunate that I can eat all the salty foods that I enjoy. Mataas na nga yung salt niya, so dapat bawasan na ang salt. I am fortunate that I do not need to follow any special diet. Of course, none. So, letter A will be the answer. 24. The nurse caring for the client with Addison would expect to note which of the following on assessment of the client. Again, Addison, think of the S, mababa ang 3 S, pero mataas ang kanyang potassium. Okay? So, kung mababa ang 3 S, meron siyang hypoglycemia, mababa ang androgen, meron siyang hyponatremia. So, is it A? Obese ba sila? Sinong obese? Cushing. Edema? Cushing. Hypotension. It is your Addison. Hirsutism, Cushing din yan. Kasi pag Addison dapat alopecia. So, hypotension because of the low sodium. Pag mababa ang sodium, mababa ang tubig. Pag mababa ang tubig, mababa ang BP. Last number for this portion, number 25. A nurse is reviewing the laboratory test result for a client with Cushing syndrome. Which of the following lab finding would the nurse expect to note in this client? Again, always remember, increase S, decrease potassium. So, alin dyan ang consistent sa ating Cushing? Letter A, blood glucose of 60 milligrams per DL. That is normal. No? So, ang normal natin is 60 to 110. Potassium level of 2.8. The normal is 3.5 to 5. So, definitely, mababa yan. Consistent? Yes, consistent siya sa ating Cushing. Serum calcium, 4.5 to 5.5 mg per liter. Normal yan. Pag milligrams per DL ang gagamitin natin, it's 9 to 10.5 or 9 to 11. Serum sodium of 135, that's normal because normal is 135 to 145. So, ang consistent dyan sa ating Cushing, it's letter Y. Potassium level of 2.8, indicating now hypokalemia. So, kung may hypokalemia, anong makikita natin sa ating ECG? Meron siyang U wave. Okay, so there you go. That ends part 1 of our ratio. See you again sa susunod na part ng ating discussion.